This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffy, who is a paramedic and communications professor.
Welcome to the EMS Research Vlog and Podcast from the studio here in Houston, Texas. I want to start out by drawing your attention to our website where you can check out anything that's show related when you go to professorbram.com. That's professorbram.com. At the website, you can find the latest show, see my talks in the media, order the latest book, and also look at how to participate in research. This is all stuff that can help you grow in the world of EMS research. Like right now, I have a research study open for first responders. So if you don't mind being interviewed by me, then go to my website at professorbram.com and click on the current research tab to apply. Hey, it's really good that we get to spend time together today with Tanner Smida, who's an advanced EMT with Tucker County Ambulance Authority, and he's currently pursuing his MD/PhD at West Virginia University. He studies things like optimizing resuscitation techniques, evaluating advanced airway management devices, and understanding the impact of physiological factors on patient outcomes. And then I just think that the amount of work that you have put in is amazing. And so that's why I want to say welcome to the show. Glad to have you. And so also, what got you here? What initially drew you to focus on out of hospital cardiac arrest and all this pre-hospital care research?
Yeah, absolutely. And thanks for having me. So initially, I started off very distant from pre-hospital care and out-of-hospital cardiac arrest. So when I started as an undergrad at the University of Pittsburgh, I wanted to do tumor immunotherapy research. So cancer biology, much more in a laboratory at the bench. But then while I was going to college at the University of Pittsburgh, I became certified as an EMT just to get an elective credit and totally fell in love with emergency medicine. And I was actually able to find a lab at the University of Pittsburgh that did cardiac arrest research. So it's led by James Manigazzi and David Salcido. And so they had both a pig lab where they did experiments on new techniques and medications in order to better resuscitate out of hospital cardiac arrest patients. And then they also have access to nationwide data sets of both pre-hospital and in-hospital data that enable them to conduct epidemiologic work and some of the large database studies similar to the ones that we'll be talking about today. And so while I was with them working on some projects under their guidance, that's when I was really bitten by the bug and decided that EMS research and specifically focusing on out-of-hospital cardiac arrest science is something I wanted to do with the rest of my career. And so I'm now continuing to pursue that. I'm going through the MD PhD program at West Virginia University. My dissertation focuses on the delivery of advanced life support to cardiac arrest patients.
Okay, so this is your love and your field. But gosh, I don't know a lot of undergrads who are doing publishable research. So how did that all come together? Was like, for example, like the IRB process as an undergrad, I think that would be overwhelming. So they were there to help you, I guess, is part of what you're saying. Is that how you accomplished? Because I want to emphasize that you have published a mountain of work, and so it's just really impressive that I wouldn't have been able to do it without getting through grad school to learn. So
certainly mentorship is a key part of that, so going in, having mentors who, for some of the projects we did, there were already standing IRBs that allowed us to kind of query these de-identified data sets. And so certainly for undergraduates who are working in a laboratory setting, right, that it certainly takes a lot more work and more time to produce a publishable unit. And I sort of lucked out going at things from the epidemiology and public health perspective. A lot of data is out there. It's already been collected. It's ready to be analyzed. And so as much work as you're willing to put in, that kind of leads to publishable units and really actionable data a lot faster. So part of that is a byproduct of kind of the field of EMS pre-hospital care research and how that work is being done. And kind of the bar for publication in comparison to other fields.
The actionable research that you did that just really caught my eye had to do with looking at amiodarone and lidocaine. And part of the reason why I I like the study is because there are a lot of paramedics who have both of these drugs in their bag and literally can choose in a way so that they flip a coin. I've for a long time have had my protocols are such that it literally is up to me, that no A or B, no problem. And so it's not that that's a bad thing. It's just an interesting situation to be in, because I want to do the very best thing, and I want to be able to assess my situation and the patient for the best drug, and for me to almost have no difference, when it comes to the choice is concerning, because I would think that we would understand more about this by now. But your study just now came out, a retrospective target trial emulation comparing amiodarone and lidocaine for adult out of hospital cardiac arrest resuscitation. And you published this in Resuscitation 2025, so fresh out. I just want to read some stuff about it before getting into questions. This study looked at these two drugs, amiodarone and lidocaine, and this is what we use to help patients that suffer from a severe cardiac arrest where the heart rhythm won't return to normal. So the goal was to see which medication worked better at improving these key outcomes, like getting the heart beating again, right, ROSC, and reducing the number of shocks needed to restart the heart, and increasing survival until hospital discharge, which is the ultimate goal, is a recovery that we can put a stamp on. So researchers analyzed data from over 23,000 patients treated by EMS teams from a period of 2018 to 2023. And they focused on patients who had a shockable heart rhythm and received one of the two drugs during the resuscitation. And a method called propensity score matching was used to make fair comparisons between the two groups. The results showed that lidocaine was more effective than amiodarone in several ways. So lidocaine increased the chances of ROSC with 36% versus 30.4% with amiodarone. And so the number means that basically we're looking at around a 6% difference in an improvement chance when we are able to stand back and look at all this conglomerate grouping of studies. Patients who received lidocaine needed fewer defibrillator shocks after the drug was given, and lidocaine was linked with a higher chance of surviving until hospital discharge. So it was kind of like lidocaine looked good in this study. And the study concluded that for this specific situation, lidocaine may be a better choice than amiodarone, to improve patient outcomes. So tell me, Tanner, did I explain the study correctly? What did I miss?
No, yeah, I think that was an excellent summary. So yeah, basically, the bottom line, in comparison to the amiodarone, lidocaine was the winner. Lidocaine was associated with greater odds of ROSC, greater odds of survival, and those findings were also consistent across a number of subgroups that we examined. So subgroups defined by age and witness status, drug delivery mechanisms, so whether you gave it through an IV or an IO, as well as the timing of drug administration. So it seemed like we were seeing a consistent signal in our cohort. So in addition, we also performed a number of secondary analyses as well, to kind of explore some possible weaknesses of our conclusions and shore up our conclusions. One of the big concerns that we had was that the practice of lidocaine administration at the agency level might be linked to other facets of care, right? And so, for example, maybe agencies that administer primarily lidocaine differ in terms of how rural they are, or the financial resources that these agencies have. So lidocaine is a lot less expensive than amiodarone. So maybe poor rural agencies would be more likely to administer lidocaine, for instance. And so as a way to address this, we had almost 2,000 EMS agencies that actually contributed patients to this study. And so we looked at the agency level at antiarrhythmic administration practices. And what we found was that most agencies either administered 100% amiodarone or 100% lidocaine during the study period. And there were some that had some mix. And so what we did was we basically, for each EMS agency, we labeled that agency as either being amiodarone predominant if they administered 80% or more amiodarone, or lidocaine predominant if they administered 80% or more lidocaine. And then we went back to the full ESO data set and we said, does being treated by a lidocaine predominant agency predict survival, even if you didn't receive antiarrhythmics, right? So basically trying to look in isolation, are lidocaine administering agencies, are they better at resuscitation overall or worse at resuscitation overall? And so, well, interestingly, what we found is that among all patients, among patients with non-shockable rhythms, and patients who had initially shockable rhythms but never received antiarrhythmics for whatever reason, being resuscitated by a lidocaine predominant agency was associated with decreased odds of ROSC. So it suggests that overall, the agencies that use primarily lidocaine, they actually might be worse at resuscitation overall, which suggests that any benefit that we found in this study to lidocaine can't be attributed to those agencies just being better at resuscitation outside of their antiarrhythmic administration practices. So that kind of strengthens our findings a little bit as well. We also knew from previous research, not only in cardiac arrest patients, but also patients who were experiencing, for example, VTAC with a pulse, that amiodarone is associated with some hemodynamic compromise. So it's been linked with bradycardia, hypotension, and in some previous trials in cardiac arrest, the need for prehospital transcutaneous pacing. And so we did some subgroup analyses looking just at patients who had return of spontaneous circulation and then had vital signs acquired in the pre-hospital setting. And we found that patients, kind of along the lines of what we would expect, patients who got amiodarone were more likely to have bradycardia, more likely to experience hypotension, and more likely to require pre-hospital transcutaneous pacing. So patients who got resuscitated with lidocaine, not only did they get ROSC more often, but they were more stable once ROSC was actually achieved. So there's some subgroup analyses, secondary findings to throw out there as well.
Actual practice, it seems like we talk about this as an either or kind of thing. Is what got you into this? Was it because you were seeing the same thing, that like the folks are just using the same thing and there's nothing to back it up? Or were there any other studies that sort of helped you frame this as an idea to embark on? Tell me
Yeah,
more about it.
absolutely. So this was actually started out as a somewhat academic exercise. Our group has been using, and maybe we can talk about this next, a method called target trial emulation, which is essentially a published set of methods that are designed to minimize common sources of bias in observational research. And some recent validation studies of this method have suggested that if you have a question that is amenable to emulation and you have a data set with all of the required data points, if you use that method, the estimate of effect size you can get, there's a high probability that estimate of effect size will be similar to what you would get from a randomized controlled trial, right? And so we wanted to emulate a previous randomized controlled trial that compared amiodarone to lidocaine, the ALPS study, and to basically see if the estimates of effect size we could get from ESO were similar to the estimates of effect size that were basically derived from that clinical trial.
Mm-hmm.
And so the ALP study was so 3-arm randomized controlled trial, double-blind, placebo-controlled. They compared amiodarone to lidocaine to placebo in the pre-hospital setting for patients who failed at least one defibrillation attempt. And the bottom line of that trial was that there was no difference between the three groups in terms of survival to discharge or neurologically intact survival. And so that kind of led to the recommendations that we've talked about, right? Basically, amiodarone and lidocaine are considered equivalent in these international guidelines. And so we started out basically just trying as an experiment. We wanted to use ESO to emulate that trial to see if we could get similar results. So interestingly, in that trial, although the three groups were equivalent in terms of survival and discharge with a good neurologic outcome, more patients in that trial actually had ROSC at emergency department arrival in comparison to amiodarone. And so in our trial, the effect size for return of spontaneous circulation was about 5.6%. That was the advantage to lidocaine. And in the ALPS trial, it was 4%. So we got pretty close with our methodology. So it's kind of a long way to answer your question, but the reason we wanted to try to answer this question using ESO is because there was a prior randomized controlled trial, and because there is kind of equivalence out there in the literature. Also, now there are some problems with the ALPS trial. One of the problems is that the version of amiodarone that is available today in the United States and used primarily on ambulances is not actually the version of amiodarone that was used in the ALPS trial. So the amiodarone that's available that we give, that we draw up out of the 2 vials, give 300 milligrams as our first dose. It's the diluent is a substance called polysorbate 80. And that diluent has been associated with negative hemodynamic effects, the bradycardia and the hypotension that I talked about before. Now, for the ALPS trial, because they were worried about the confounding influence of this, the substance used to dissolve the drug, they actually used a special formulation of amiodarone. It was formulated differently, so it didn't have that polysorbate 80 in it. And so kind of in addition, and this is something that kind of came to our group's attention after we'd already done the study and we're writing the discussion, the ALPS trial is not actually a fair comparison of the 2 drugs that are out there today. And that might also have influenced the difference in outcomes between the 2 groups that we observed. So.
All right. So when you have this much data to manage, was some of this, did the ESO team help you with some of this? Did you use a software program? I know this is complex. So what kind of strategies did you use to make it all work out?
Yeah, so when we're working with these large data sets, we typically use software packages that they're designed to facilitate data management and statistical analysis. And so, quite frankly, whether we're analyzing 200 patients or 200,000 patients, the code that you write within these software programs is pretty much the same, right? And so, personally, for this study, and what I use most frequently is a software program called Stata. And so, I guess that goes to show, when you're reading a study with a ton of patients, that doesn't necessarily mean that it's more complicated or difficult to analyze that data in comparison to a smaller study. It might be harder to collect that data, but not necessarily harder to analyze.
Yeah. Well, it depends on I guess, what the factors are involved. And so I wanted to get your help because this is not my specialty. Can you tell me more about propensity score matching and then also the target trial emulation? Can you help me understand how that worked out to give you all a good, clear picture of what's going on?
Sure. Yeah. So I'll start with target trial emulation and then bring in the propensity score matching because they go together, right? So as I said, right, target trial emulation, it's a published set of methods. It's basically a checklist of things that you should do when you're running an observational study to eliminate common sources of bias. So the first, and there's a number of steps here. The first one is when you're picking your eligibility criteria for your study, you have to make sure that your eligibility criteria are comprised of information that is available to clinicians at the time of treatment administration. I'll give you an example of why this is important related to amiodarone and lidocaine, because this question has been examined a couple times before in observational studies, and this mistake has been made in the literature. So some of these investigators, whenever they're studying amio versus lidocaine, they'd exclude patients who got both drugs, right? Now, the reason that this isn't a good idea is because if you have 2 antiarrhythmics with differential effectiveness, the first drug you administer might modify your probability of requiring a second drug, right? So if you give a first drug that doesn't work, you're more likely to require that second drug. And if so you eliminate that patient population, you're really eliminating a patient population that got harmed by that first drug because they were in cardiac arrest for a longer period of time, right? And so that can bias your effect size toward the null. So that's one thing that this eligibility criteria checkbox kind of helps address with target trial emulation.
Awesome. Okay.
They also require, or the method also requires, you have to clearly define your treatment strategy, reasons for basically, allocating a patient to one treatment group or another, clearly defining your outcomes of interest, right? And these are kind of things we should be doing with all research anyway, but this is just kind of a formalized structure, right? It also requires that you pick a time zero that is consistent across both treatment groups. That is important. You need to pick a time at which patients are both eligible for treatment and are allocated to a treatment arm. And then finally, a time point at which follow-up begins for your outcomes of interest. This is a big problem because of something called immortal time bias. And then there's another related bias that's specifically a problem in cardiac arrest research called resuscitation time bias, where if you basically, through the way that you're analyzing the data, through your methodology, if you have different intervals of follow-up or different intervals of time that pass before treatments are administered in one group or another, you can basically artificially bias the incidence or prevalence of an outcome of interest. And so kind of defining a time zero and a follow-up interval takes care of that. And then finally, because with observational studies, confounding variables are an ever-present problem, you also have to use some sort of statistical method to control for confounding and baseline imbalances between groups. And so you can do that using, there's, regression, there's matching, like propensity score matching. All of these are basically equal in the eyes of the target trial emulation methodology, as long as they're well done. So, again, so I said, right, confounding variables are a big problem. A confounding variable is a variable that is associated with both an exposure, so in this case, amiodarone or lidocaine administration, and then that variable also needs to be associated with outcomes. And so we'll take witness status, for instance, right? We know that witness cardiac arrest patients have a better chance of survival. And so if we had two drugs, and let's call them drug A and drug B, and more patients in the drug A group had unwitnessed cardiac arrests, right? Witness status becomes associated with drug A, and then we know that witness status is also associated with outcome. And so if you did an analysis without any adjustment for confounding variables, you would conclude that drug A is harmful to patients, right? But that's not true. That's just because more patients in the drug A group had unwitnessed cardiac arrests, right? It's kind of a brief explanation of what confounding is there. And so propensity score matching helps us account for that. And so the way we did this is we started out with a logistic regression model. Logistic regression models are good at modeling binary outcomes. So either you got ROSC or you didn't, you survived or you didn't, right? These are, a lot of analyses we do in pre-hospital care research. And so we use a logistic regression model adjusted for a bunch of different baseline covariables that we know are associated with outcomes following cardiac arrest. Things like age, bystander CPR, initial rhythm, the time it took medics to get there, right? And then the output of that logistic regression model in kind of most papers that use regression, they'll output it as an odds ratio most of the time. But the output of that model can also be kind of quantified as a predicted probability. So you can get a predicted probability of, any outcome. So, but for our propensity score matching analyses, we use the predicted outcome of receiving lidocaine as an antiarrhythmic during cardiac arrest.
How many different variables are we talking about that you had to take into account?
Yes, so we used, and I can count here. I have the paper pulled up, but we
basically, you don't have to. I'm just thinking it all around, roundabout, because it sounds very complicated.
It was about 10 or 12 variables. So age, sex, witness status, whether or not bystander CPR was performed, the response interval, the initial rhythm, so whether that was VFib, VTAC, or just an AED shockable rhythm, and they didn't specify. Etiology, location of cardiac arrest, as well as the type of vascular access, the time to initial drug administration, and the number of pre-drug defibrillations. So that's what we used. Despite all of our efforts to adjust for bias, so something we took that predicted probability, right, that comes out of the regression model, and then we take patients who received amiodarone and lidocaine, and we match them based on the similarity of that propensity score that results from our logistic regression model, right? And so we have two groups of patients with similar baseline characteristics, so they should be balanced with respect to known confounders, right? The confounders that we put into our model, right? And so that makes these groups comparable, and we can compare outcomes across groups. Now, that said, right, this is still a retrospective observational study. There's still the potential of influence from either confounders that were not measured in our data set, or are unknown, right? So things that we don't even know influence outcome at this point in time with the state of the science that exists right now. And so it's really important, with these studies, we are only able to adjust for known confounders that are measured in this data set. And so I think it's hard to make an argument for modifying any guidelines or modifying clinical practice based on our study. And there was an editorial published in the Journal of Resuscitation recently about this paper. They basically said, we can probably make the claim that lidocaine is at least a safe alternative to amiodarone. But while we did the best we could with the available data, causal inference, in kind of from a strict scientific viewpoint, it requires experimentation. It requires a prospective randomized controlled trial. So I really don't think we're going to see any guideline changes based on this work.
Yeah, and so isn't the best way to sort of pick apart what you did here is to look at how you did some of this score matching and what factors you take into account, because that's that's what someone else could say, oh, if we would have only had this, or if we would have not had to account for that. I don't know how else they could pick apart what you're doing here, other than those factors.
Yeah, absolutely. And the reviewers certainly did try to do that, right? So that they actually, if you look in the supplemental material, we have a bunch of actually additional models with more variables. So we looked at advanced airway management strategy. We looked at epinephrine administration. They had us add some additional like timing variables in there. And so, again, while we did the best we could with this data set, we tried to use everything that was available in ESO. For example, we didn't account for things like socioeconomic status, right, or insurance status, right, things that have been previously associated with outcome but just aren't available in these pre-hospital data sets. And I guess I'll say this. Another important limitation is that our primary outcome for this study was ROSC, right, return to spontaneous circulation, whereas really we're interested in neurologically intact survival, right? That's what patients care about, and that wasn't available in this data set. We were able to look for a small subset of patients. So about 20% of transported patients in this data set have hospital disposition data, so we can tell who survives the hospital discharge. The problem there could be related to something called collider bias. And so essentially, we have a treatment that can modify ROSC, right, or is at least associated with ROSC. And ROSC is associated with the probability of transport. And all patients with outcome data were transported to a hospital. And so when you have a factor that can modify the probability of a variable that you use to stratify patients, that can lead to something called collider bias and might kind of distort the relationship between the antiarrhythmic drug and survival to hospital discharge. And so, maybe a next step would be to, examine this same question in the CARES data set, the Cardiac Arrest Registry to Enhance Survival. It's a lot larger. It has complete neurologic outcome data and survival to hospital discharge data for all patients, not just the ones who are transported. Although that data set has its own limitations, including, like nothing's time-stamped in there. You can't tell, for example, of the patients who received both amiodarone and lidocaine, you can't tell which drug was administered first. So, again, it's a sticky and tricky question to answer. I hope this spurs future discussion.
Because this is what it takes. And so what do you see is happening next in this realm of EMS research with resuscitation?
Yeah, so I think that the use of target trial emulation, as I described it, has a lot of potential for improving the quality of pre-hospital care research that's out there. So, there are a lot of studies that are published every year that are afflicted with some of the common sources of bias that I described, right? So the resuscitation time bias, immortal time bias, inappropriate inclusion and exclusion criteria, inappropriate statistical modeling strategies. And so I think that using this paper and the other papers that we published using target trial emulation is kind of as an example for other people in the field to follow, can potentially improve the quality of observational data in our field overall, and kind of give us a better idea of which interventions are actually worth sinking money and time into and studying with randomized controlled trials, as well as kind of generating accurate estimates of effect size so we can adequately power those randomized controlled trials and calculate, necessary sample sizes and things like that. So my biggest takeaway would be, I think that this is a good method, and I think that more people should be using it.
Well, right on. And thank you for, bringing this in. What is there, before we go, is there anything else that you want to share or add to our talk today?
I don't think so. I think we covered most of it. I'll say I'll say that so if anyone is interested in this method or wants to reach out to talk about the paper, the conclusions, anything related to EMS research or cardiac arrest, feel free to reach out. My email is tts00004 at mix.wvu.edu. Dr. Duffy, I don't know if you'll put that in the show notes or if there's a way for listeners to get that, but
Sure, I'll put
happy
it down there,
happy
and
to
that's
talk.
it got 4 zeros in the middle, right?
I know, yeah, it's a mouthful.
No, it's awesome. And good stuff. I'll have that in there. And keep up the good work. Congratulations on your accomplishments. So, Tanner, thank you again for joining us. Like many of you, I'm also an EMS instructor. So I know what it's like to have topics that are important to cover, but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research or even talk about how things are done differently where I am versus where you are. So, if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
With a badge.
Yeah. And you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplow from the International Prehospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for your review on our website at iphmi.com and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field or what we should be doing in the field or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and they're all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business. This is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.